we can isolate different parts of the immune system and we can target it outside of the body now, or in vivo where the body becomes a bioreactor.
Yeah. Carl, good to see you again.
Yeah.
So as the pioneer, one of the pioneers certainly of the CAR T field, we're now seeing technologies like in vivo CARs, the making of CARs inside the human body. How do you see this evolving in terms of influencing the cell therapy field?
Well, first of all, I think the fact that we're now having a totally new modality is really great for the field. And I think you have to look at it in a couple of ways. One is what the indications for, and we have at this point two major, which is in one case oncology indications, and the other would be autoimmune disease and I think regenerative medicine. Now, in the space of oncology indications, there are, the willingness to give chemotherapy along with a say in vivo CAR is very different than an autoimmune disease patient who's treated by usually a rheumatologist or maybe a neurologist. So the patient populations are very different. And then I always look at the CARs right now are cell therapies that are made ex vivo. And they're not just autologous, but we also have allogeneic cell therapies. So where you could make it, say, from cord blood or from even induced pluripotent stem cells.
So it can be off the shelf.
So they can be off the shelf, because that's a major differentiator we found at the patient and provider area is if it's off the shelf and can be given on demand. And that's a big advantage of an in vivo delivered CAR. And now the ex vivo are not going to go away because you can do much higher levels of engineering, gene editing, site-specific integrations, multiplex gene deletions, which I think is going to be the sweet spot for solid cancers. So we have to remember we're going to have now in vivo, which will be lipid nanoparticles, probably in vivo viral vectors, live viral vectors, and then ex vivo continued engineering. And they're not going to go away. I think that what they are is expanding the reach, and it will make, so there's just different platforms, and each disease indication will have different sweet spots.
That makes sense. So, I mean, for you, this must be an interesting time, isn't it? You started off with immunology background, spent a lot of time on oncology, and now you're being drawn into rheumatology, right? Is that what's happening for you?
Yeah, I mean, it's actually a full circle because I started in autoimmune disease.
You did?
My first papers out of my lab were on multiple sclerosis models in mice.
Oh.
And my mother had lupus. My daughters have autoimmune disease. So in my family, we've had autoimmune disease. And so I started in autoimmunity and tolerance, and then, started working in the first places for CAR T cells in obvious areas were cancer. And so to see this field explode at this rate is a complete, was not predictable really. I mean, because I had seen hesitance by rheumatologists who are very conservative by nature on giving something that might cause very bad cytokine release syndrome. And we found out, in fact, it's less, not more. When you treat an autoimmune disease patient, at least so far, the side effects are much less than in cancer patients. So that was counterintuitive. And we've seen now a rapid adoption there of people to use CAR T cells for non-lethal indications. And that was not even conceivable 5 years ago.
Indeed.
Was not conceivable. I couldn't get approval in the United States to do a trial like that. And then it happened, as you know, it happened in China and in Germany, where they tested, CAR T cells for patients outside of autoimmune disease, and they had striking results.
Yeah, that's remarkable for the autoimmune patients, isn't it? So as we go forward now, the attention has always been on T cells, but clearly there are regulatory T cells, there are natural killer cells, there are gamma delta T cells. And do you think all these immune cells will be re-engineered, playing a role both ex vivo and in vivo? What are your thoughts on that?
So I mean, we know, I mean, I think the AIDS epidemic taught us initially how critical T cells are for people. You know, without T cells, you die pretty rapidly. And then we learned during the COVID epidemic about B cells making antibodies against spike protein and so on. And we now know that you can live for a while without B cells by giving CARs that wipe out all of your B cells. And we know for autoimmune disease, it's important that you wipe them all out. That's one of the big lessons so far. The depth of B cell depletion is important. But we know that the immune system's a big orchestra. It's the many different subtypes of cells, like you said. Natural killer cells, there's striking data with CAR NK cells now.
Uh-huh.
There are data with CAR monocytes, CAR macrophages, you know, different subsets of T cells. There are CAR Tregs.
Tregs and gamma deltas.
Yeah. And CAR Tregs being made and tested for autoimmune disease. Gamma delta cells have very interesting, you can use them off the shelf and not have to match them, you know, as N of one from that same person. So, and they each have different lifespans, sweet spots where they like to home.
Yes.
And so we're going to get finer and finer approaches of these different modalities. And I think the bright spot is the toolboxes. So lentiviruses, adenoviruses, lipid nanoparticles, all of those. And then we can isolate different parts of the immune system and we can target it outside of the body now or in vivo where the body becomes a bioreactor.
Absolutely. Exciting future ahead. Thank you very much, Carl. Thanks for chatting with me today. Appreciate it.
Okay.
Thank you.
Pleasure, Christopher.
Thank
Thanks.
you.
Yep.